going to transition to questions and answers, and I suspect there's probably some questions queued up for us.
There certainly are. So thank you so much, everyone. That was a really informative discussion. I do have a couple of questions that have come in. One is, again, going back to the topic of mucus production. And I know you'd mentioned staying hydrated and some of the other things that you have learned over time. But the questions are really looking at, does the mucus production, like how much is produced, and does it decrease or go away over time? Does your diet affect that at all, or is it just as much liquid as you have? How do you control the amount of mucus? Is there anything that you or Lydia have found that helps to limit the amount of mucus? Or Dr. Daneshmand, if you have any suggestions for folks.
Yeah, I can just say some general sense. So the mucus comes from the intestinal tract producing this material that helps in digestion of food. So despite the fact that now urine's going through this, there are some changes within the lining that flatten out the absorptive capacity of the neobladder. It's still, at the end of the day, it's ileum, and it produces mucus. So it'll decrease with time. It'll always be there. But probably about a year out or so, you'll notice there's very little of it, and it's not an issue for most patients. Production, I have heard many patients say, you know, when I'm dehydrated, I get more thicker mucus, or for some reason I had this meal and I had to produce more. Well, you know, this is not connected to your intestinal tract, so it's completely separate. You know, it doesn't traverse through the intestinal tract. So, and most likely those foods and all the, you know, has to do with hydration level and less to do with what you're eating.
That's a really good point. Lydia and Rick, did you have any suggestions that you've used that have helped you control this as an issue?
I think, oh, go ahead, Rick.
Yeah, I was gonna say, you know, for me, I'm 14 years out, so I have the 2006 model year. And so you know, when I first, you know, after I first came out of surgery, it literally was like egg drop soup, and I hope nobody's eating as we're talking. And so you can imagine to me that was a lot of mucus. I don't notice, I barely notice the mucus anymore. I mean, it's so such a small amount. It does tend to empty first, but I don't really notice anything, but I do keep well hydrated. So, you know, maybe if I didn't keep hydrated, that I would have more of an issue. But I barely notice it anymore.
Okay. Lydia, anything else before we switch to the next question?
No, I would agree that it has decreased over time, but I do still have noticeable, but it does correlate with hydration. And I thought perhaps certain foods or medications, but again, that might be a correlation more with hydration.
Right, okay. Should neobladder patients avoid contact sports? Similar types of activities, really heavy physical activities. Is that a problem?
No. The short answer is no. You know, once everything is healed, there's no limitation as far as activities go. You know, there are abdominal muscles in front of the neobladder that are fairly strong that protect the neobladder the same way. And plus, it's your body. It's very highly flexible inside. So if you do sustain damage or get into an accident or anything, it pretty much acts the same way as the bladder goes. It is a bit thinner, so if you get into a major accident, the chances of rupture are slightly higher, but that's an extremely rare situation.
Can a neobladder be resized if it stretches too large? Is that a problem that you ever have seen, Dr. Daneshmand?
Yeah, absolutely. So there are patients who don't realize it and their neobladder gets really stretched out. I've seen up to 2 liters in a neobladder, which is a tremendous amount. It turns out after a while, it actually goes back to fairly normal size. It doesn't stretch to that level and then stay stretched and become a floppy bag. So there's no need to decrease the size of neobladder. I have had one situation where I had to increase the size of the neobladder because for whatever reason it had really shrunk down. This was not one done by myself. It was from outside, and I still to this day don't understand. I suspect that they didn't take enough long enough segment of ileum for it to stretch. But so we increased the size of that neobladder, but the other way around, we don't need to do that.
Mm-hmm. So the follow-up question: what anatomical changes subtend increased neobladder capacity over time? Things like decreased edema, stretching of bowel tissue, smooth bowel wall, muscle relaxation. Are there any anatomical changes that can impact neobladder capacity?
Yeah, so basically the bowel stretches, the bowel wall stretches in a normal, as it holds more and more. It's one of those parts of the body that actually will stretch naturally. And just like the uterus stretches with pregnancy, there's certain parts of the body that can be stretched. The skin can be stretched. So there's actual duplication of the cells and replication to the point where it does the work, and it remains. The most important thing is that it remains a low pressure reservoir. That's what it's meant to be. It's in fact a lower pressure than the normal bladder is.
Okay, a quick question here that came in a little bit earlier. Should I be finding a primary care physician and or a urologist that's familiar with neobladder, since this individual's regular PCP is not really familiar with that? Do you think that's an important factor, that they need to be more familiar with the neobladder?
Yeah,
I think
I think it's important for a couple of reasons. Like Rick mentioned and Lydia had mentioned, that there are long-term changes that can occur that if you don't notice them over time, things will happen. Things like vitamin B12 deficiency and the bicarbonate level, which is of critical importance. I think there's another question here about metabolic acidosis. It's actually somewhat frequent, and the more renal dysfunction you have, the more chance of having metabolic acidosis. So many people don't recognize this. They look at the sodium, they look at the potassium, they don't really look at the CO2 levels normally. And if this is chronically low, then the patients can develop bone loss, and over a 5-year period of time lead to fractures and things like that. So I think it is important. Other things we see on the other side is routinely primary care physicians will do a urinalysis on a patient with a neobladder, which invariably leads to white cells and red cells out of range of normal. And they will call the patient, or their nurse will call and say, "You have an infection." Well, and they get treated with antibiotics unnecessarily, and the patient is completely asymptomatic and absolutely does not have an infection, and really should not be treated with antibiotics. So we have to re-educate the patient and the primary care physicians that don't do a urinalysis on a patient with a neobladder, or any diversion for that matter, because what you see on a urinalysis is completely irrelevant. This is not a bladder urine, this is a neobladder urine, so you're going to see lots of things. So I think it's important that patients educate themselves also, and when someone's checking their urine, ask, what are you checking for? Because that's just a part of routine primary care annual sort of physical.
Mm-hmm. So really, it does help to have that owner's manual, if you were going to go with this car analogy, so you can point this out and say, hey, look, these are some things as my primary care provider you should recognize and you should know. And if you have any questions, make sure that you let me know so I can get the answers for you from my urologist who did my surgery. I think that's a good idea.
Exactly.
So looking at going on that car analogy, there was a question about the warranties. What's the average lifespan of a neobladder?
Rick is, 14 years out now, Rick?
That's right.
So the expiration date is 15 years, so you're going to have to go in for the new model. So no such thing. Actually, one of the few things in life that gets better with age, meaning this is completely part of your own body. Your body recognizes the tissue, it changes in a good way usually, and there's really no expiration date on neobladders. It just is completely a part of your own body. So it's lifelong warranty here.
Excellent, excellent. So like a good Volvo that, you know, can go for a few 100,000 miles. You can just keep going, which is good. So talk a little bit, if you don't mind, about kidney and bladder stones. You know, how do they develop? How do you get rid of them? How do you avoid them?
Okay, that's a good question. And I think, again, Rick had a good tip there about drinking lots of water. So kidney stones, so having a neobladder doesn't put you at increased risk of developing kidney stones per se. If you were a patient who was prone to developing kidney stones, you'll develop them again. Also, poor emptying. So if you do have small little kidney stones and you're not emptying your neobladder well, then it can stay there and result in a bigger and bigger stone. Now, those are the types of things we check on your, 6-month visits, annual visits. We're checking those for exactly those things. They're not common. Neobladder stones are fairly uncommon. The neobladder, eventually the stones kind of come out on their own. If you do develop a kidney stone or a neobladder stone, they're treated the same way we do the normal kidney stones, except it is more difficult to get up there. As I showed you the pictures of how this is reconstructed, the ureters are a little bit further from our reach and difficult because you've got this twisted turning segment of bowel that flops to one side or the other, and it's harder to access the upper tract. So it becomes a little bit more challenge. You need a really good endourologist who's versed at treating kidney stones, specifically in neobladder patients. The shockwave lithotripsy is the same. Some of these stones are shocked. Neobladder stones are very easy to manage. We just look in there, grab it, and pull it out if it's small. If it's really large, we sit there and laser it, and those are unusual. They're a little bit more common with the Indiana pouches because invariably those don't empty completely, and they're dependent portions of it that hold the urine and develop stones. So a little bit more common in the continent cutaneous diversions, or Indiana pouch is one of them.
Great, those are good suggestions and information. So if continence can't be achieved after an appropriate period of time, is there anything that can be done surgically or non-surgically to correct this problem? Dr. Daneshmand, do you work with a pelvic floor physical therapist at all? Like, is there any process that you can do that might help someone to have better control of their bladder once they have that neobladder?
Yeah, that's a great question, and Lydia brought this up. To make sure that your center has a physical therapy program or pelvic floor rehab program, pelvic floor physical therapy. Many of them are versed in getting patients post-prostatectomy back to continence, and there's more and more science behind pelvic floor rehabilitation. So absolutely, we have one. They're very well versed in neobladders specifically. And actually, Eileen Johnson, who's one of our leads at our center, wrote the chapter for me in that book that I showed you. So that's one. The next question is, what if I've done all that? It's been a year. I'm still leaking during the day, or I have really bad incontinence at night, and I catheterize, and I'm just not happy. Is there something you can do? And the answer is absolutely. There's an artificial urinary sphincter that can be placed. That goes around the urethra for men only, unfortunately, just because of anatomical limitations in women. So men would then press and squeeze a button in their scrotum, and this would allow the valve to open and allow the urine to expel from the neobladder, and then it automatically sort of closes. So they essentially become completely continent. Now, it's not as simple as I say, because the surgery really has to be done by an absolute expert. The bladder is not in the right place. The prostate has been removed. The anatomy is different, so they have to be very, very familiar with placing this artificial urinary sphincter. Absolutely has to be done in a center that is very, very versed in this.
Mm-hmm. Good. Okay, thank you. Does having bilateral nerve-sparing radical cystectomy technique enhance continence in addition to enhancing possible erectile function in men?
Oh, wow. That is a very good question. So erectile function, for sure, there's no question those nerves are controlling erectile function. So when we do a nerve-sparing operation, we are trying to preserve erectile function in men. Let me just mention also in women that there are different kinds of nerves on the side or the lateral aspect of the vagina that are also involved in sexual function. And we try to now more and more preserve those nerves in women who are sexually active. So the question is, does nerve sparing alter or improve continence when you do a nerve sparing operation? It's a tough question to answer. We tried to answer that question. It seemed like when we looked back at our nerve sparing approaches, the answer was yes. Nerve sparing approaches did improve continence. But the problem with that statistic is that we tended to do the nerve sparing on the younger patients. So, before I showed you older patients have similar continence as the younger one, but this is called the confounding variables. So the short answer is we think so. I can't tell you 100% that does anything. So do we try to do a nerve sparing approach on a patient who already has erectile dysfunction for continence? Short answer is recently, yes. I think it probably helps, but we don't know for sure. They are different nerves that actually control continence and the urethral sphincter mechanism. So whether there's some kind of contribution there, we're not exactly sure.
Okay. Dr. Daneshmand, there's a question that's follow-up to your artificial urinary sphincter question. What percentage of patients undergo the artificial urinary sphincter implantation for incontinence after having a neobladder? I know you mentioned that you have to go to somebody who really knows what they're doing to get it installed properly.
Very
like
few.
You wouldn't take your high-end vehicle to the mechanic on the corner. You want to go to somebody that knows what your engine is all about. So what is the percentage?
Yeah, so it's very, very low. I would say probably it's got to be less than 5%. And the reason is, we offer it to the patients and they ask us, is there something that can be done? We say, yeah, physical therapy. Yes, I did that. Anything else? We talk about surgery. They say, no, I don't want surgery. And really, it's not that bad. I leak a little bit at night. And most of the time, there are also other behavioral changes, such as, again, Rick mentioned, changing your habits of how and when you drink fluids at night. That affects what you do, what happens at night as well. So if all those fail, then you go to the artificial urinary sphincter. But again, very few people have that operation.
This is a question that might be best for Lydia and Rick, but Dr. Daneshmand, you can weigh in as well. How can neobladder patients who are still incontinent go swimming? It is summertime, so that might be a very relevant question for somebody. Is there any concern about, say, swimming in a lake or a pool or whatever if you have incontinence with a neobladder?
I'm not sure how to answer that.
Okay.
I would say kids pee in the pool all the time, so don't worry about it.
Good. That's where I was going. I was like, you get the kids in the diapers, and so wear a guard maybe.
Don't wear a guard. It gets messy. I think if you're slightly incontinent, it's fine. Mm-hmm. If it's a big pool.
Well, a common thread on some of these questions is really just looking at what is an average target water volume to stay well hydrated and not overtax your neobladder.
Yeah, I think so. You constantly hear this 8 glasses of water a day, and that's a general recommendation. In the beginning, we really stress hydration because there are all kinds of changes going on. You really need to stay hydrated in the beginning, and the beginning means the first 3 months after surgery. Once everything is settled, 6 months later, a year later, really it's not a plant. You don't need to keep watering it. It functions the same way. And you know, if you notice thicker mucus, or you're developing multiple urinary tract infections because your urine is so concentrated and you have mucus buildup, then yeah, you need to drink more water. But if everything's functioning fine, you're doing well, you don't have stones, you don't have kidney infections or urine infections, then you know, the general recommendation is, as with everybody else, that 8 glasses of water a day.
Okay, great. This is a question for Dr. Daneshmand. It's kind of a combination of 2 questions. So there's no remedy for females who cannot achieve satisfactory continence after a year. And then one of the women on the call asked about having any urethral bulking agents to help with incontinence. Does it block mucus? Is that even a consideration for women, since there's no little gadget that they can use?
Great, excellent questions. The answer is yes. Let me elaborate, because this is important. So let's say women are after 1 year or 1.5 years, they've done everything, and they have significant incontinence, and they say, what can you do? I still want to keep my neobladder, but I'm very unhappy. The answer is twofold. One is yes, absolutely, we can do urethral bulking agents. Imagine collagen, but not collagen. We use something else. Somebody mentioned coaptite. It's just another agent that we use to bulk up the urethra. The results are somewhat mixed, meaning, you know, there's not enough experience with it. I'm not talking surgical experience. I mean enough data to show the improvement in continence. I have done it. Some have gotten better. Some have had no difference. It's worthwhile because it's such an easy procedure that we can do under, you know, minimal IV sedation, and it takes probably 15 to 20 minutes to do. It's very easy. So I think it's worth a try. If the problem with the female urethra is very short, and if someone wants to be completely continent, we can certainly do that with something called a sling, which is a surgery we do, or my colleagues do, for female incontinence. The problem is because when the neobladder is a low pressure system, it won't squeeze out the urine, and now you'll go the other way. You'll go from leaking to being completely continent and not being able to urinate and needing to self-catheterize. So we offer that to women, and we say, well, we can put up a sling. It'll make you completely continent, no more pads. However, you do need to catheterize, and very, very few women go for it. They would, you know, that's the lesser of 2 evils, whichever. So so it's very hard to control the tightness of that sling so that it's just right, so you're not leaking and you don't need to catheterize. It's nearly impossible.
Okay, great, thank you. There's a couple questions that have come in regarding hernias. Are hernias more likely to occur? Are there special activities that should be avoided to reduce the risk of having a hernia? And does having incisional hernias affect the working of a neobladder?
No concern at all about hernias. Are very common after any kind of surgery, and a cystectomy and neobladder or any other diversion is not immune to it. So absolutely, it's just one of those things that happens over time as the muscles get weaker and they stretch out, developing a hernia. So it's not a big deal. However, if it is a large hernia, or if it's in the lower part of the abdomen, I would really recommend you talk to your urologist if they're comfortable fixing it themselves or having them be involved with it, with the repair, because general surgeons who have done many of these hernias but are not familiar with the neobladder being in the abdomen, if they get inside the abdomen and start to mess around down there, they will absolutely not know where the neobladder is located, and it would be an absolute disaster if they get into it. So just word of caution, getting the large ones fixed.
Mm-hmm. Okay, great, thank you. This was a follow-up question on the urethral bulking agents. The concern about additional mucus blockage because of this bulking agent, is that something that you've seen when you've given this treatment to some women? Not really, no. The mucus still comes out, no. Okay. And we have time for just maybe one more question. There's a lot of chatter on the BCAN Inspire site talking about prostate capsule sparing techniques for radical cystectomy in order to enhance continence. Is there data that shows that this enhances it? Does it diminish the oncologic effectiveness of a radical cystectomy because they're not taking out the prostate or doing it in a different manner? Is there anything that we should be aware of as a patient community in looking at that?
So that's an excellent question. That's almost like a question I would get at a scientific meeting from my own colleagues. I think I see the question right there. Absolutely, it enhances continence. There's no question that if you spare the capsule and don't go right up to the edge where you're getting closer and closer to the urethral sphincter mechanism, that you're going to have all near perfect continence, actually, if it's just a prostate capsule sparing. The concern is twofold. One is, yes, it diminishes the oncological effectiveness, although there are a couple of studies from Germany that show that's not the case. We in the US and other parts of the world have not adopted this technique because we do have significant concern about the oncological safety of leaving parts of the prostate behind where urothelial carcinoma or bladder cancer can invade. Once it does invade, it's absolutely not curable. It's not like we can go do surgery and just take this part out. Usually it metastasizes, it's nasty, there's no boundaries to it. So that's the problem, it's a balance. I have done complete prostate sparing surgery where we spare the entire prostate, but those are very, very selected cases on very young patients or patients who don't have bladder cancer, urothelial cancer of the bladder, but they have sarcomas or other such cancers that don't affect the urothelium or the inner lining of the prostate.
Okay. Well, this has been incredibly informative. I greatly appreciate all of your expertise, both with performing neobladder surgery and in the living and care and keeping of these neobladders. Thank you so much, Rick and Lydia and Dr. Daneshmand. I would like to thank also
Thank you.
Our sponsors for the Patient Insight webinar series, the Estella Seattle Genetics Partnership, BMS, EMD Serono Pfizer Partnership, Fairgene, Janssen, Genentech, Merck, and PhotoCure for their support. Remember that you will be getting an email with a short program evaluation. Please take a few moments to complete that. And we hope to see you all soon on another Patient Insight webinar. Thank you all so much for joining us.
Thank you.